Here we have the case of a 14-year-old male. He has a history of waxing and waning, kind of mild patchy alopecia areata since he was about 10. And this is something that we see not infrequently, where people have a few patches, they regrow, maybe with treatment, maybe spontaneously, and then it remits for a while. But he's coming in because the hair loss has really progressed over the past several months. And in the last month or so, he's lost everything. So he has complete loss of all his scalp hair. His eyebrows and eyelashes have now been lost, and he's also noticing that his body hair is missing. This is unfortunately not an uncommon presentation that we'll see in adolescents, but really in anybody, where people have this, kind of coming and going disease, and then boom, all of a sudden it really flares up. And this, I think, especially for people who don't have any history of alopecia areata, is particularly devastating. But really for anybody, this, understandably is very hard. All of a sudden you look in the mirror and you really don't look like yourself anymore. And I think this is something, that patients really struggle with, and we really, our job is to offer them some solutions. So he, in the past, has used intralesional corticosteroids. When it was first happening a few months ago, he had some injections also, but it really continued to progress. He's using a super potent topical steroid, but his mom says, that's really becoming just kind of cumbersome and drawing a lot of attention to his scalp, and he's getting a little irritated, so he really would rather not do that. And socially, again, not surprisingly, he's having a hard time. So he is actually like a star basketball player, and he recently stopped playing because his teammates were kind of giving him a hard time. He wasn't allowed to wear a hat while he was playing, and so he finally said, I can't handle this anymore, and is no longer playing basketball. So, and this is again something that we see in, all patients, but especially adolescents, when, social life is so important, and it's really, it's kind of impossible to interact with the world in a normal way when you don't have hair, eyebrows, or eyelashes. And so we often see this withdrawal from activities. And that's something that I always ask patients about. Is there something that you used to do that you don't do anymore because of your alopecia areata? So he's a healthy guy. Otherwise, he has a history of mild eczema, which is something that we often see in patients with AA. About 30% or so of patients will have a history of atopic dermatitis. And he does have a little family history of autoimmunity. His mom has Hashimoto's, and his paternal grandmother has a history of rheumatoid arthritis. So, in this patient, we have to start thinking about treatment options, right? He's coming to us for help. And I think the things that he tried initially were certainly appropriate for mild disease. So for people with mild disease, say maybe, 15% or less hair loss, I do think intralesional corticosteroids really are, they kind of remain the mainstay of treatment. Importantly, for those patients who can tolerate it, in kids especially, that can be very difficult. Topical corticosteroids are sometimes helpful, definitely not as effective as intralesionals, but something else, to do. But once we hit, more severe disease, these things really become impractical and really aren't going to make a big difference for a patient. And I think, importantly, people who have waxing and waning disease, even though these things are helpful, sometimes that roller coaster of the up and down of having patches and getting better, but then always kind of worrying that they're going to come back, can also be really difficult. So I think patients with sort of chronic patchy disease, even when they don't have maybe really significant hair loss at any one time, I think those are patients who really warrant a conversation about systemic treatment. So, before talking about treatment, though, I think it's really important to see how the patient is doing. And I think a lot of patients, especially teenagers, tend to get a lot of positive reinforcement for coping, which, is useful because we want, to kind of applaud them for being able, to do some of the things that they used to do. But sometimes that can make it hard for kids to say how they really feel. And so one thing I often do is just say, hey, this is hard. How are you doing? And kind of put it there for them to sort of say, hey, I get it. This is a big deal. This is tough. How are you holding up? And, I think it's important for patients to feel comfortable with us, to say how they feel about it, and really to acknowledge and truly normalize the fact that this is a really devastating disease for many patients. And I think a lot of patients have heard, dismissive comments. Well, at least you're not sick, or at least, you don't have cancer, or in this case, at least he's a boy. We hear that a lot, but, I think for everybody, this is often really difficult. And I think that's a really important part of our role as HCPs to address that for patients. So in examining him, he has complete loss of all hair on his body. So his SALT score, his severity of alopecia tool, is 100 because he has lost 100% of his scalp. One way I think about SALT score is to think about the L standing for loss. So it's a measure of the amount of the scalp that's involved in hair loss. So 100 is complete loss, whereas 0 is no loss at all. He's unfortunately also lost eyebrows and eyelashes. And eyebrows and eyelashes, I think, we don't really understand or kind of appreciate the importance of them until they're missing. And, this is something that really makes us look human. They shape our face, they allow us to be expressive. And when patients lose them, I think this is a huge time when identity, really kind of feels like it's going away. They look in the mirror and feel like they don't recognize the person that they see. On his fingernails, he does have pitting of multiple nails, and nail involvement is something that we see pretty commonly with alopecia areata, and it can be very subtle, just a few pits and a few nails, or it can be very extensive with dystrophy of all nails, trichonychia, sort of a sandpaper-like appearance to the nails, which can be not only, cosmetically problematic because our hands are always there, we're using them when we talk and people see them. And so that's hard for your nails to look very different, but also nails, are functional, right? And so if you don't have nails that, if they're crumbly, if they break easily, it's harder to pick things up. It's harder to do certain things, when your nails are involved also. So this patient's SALT score is 100, and SALT is, the tool that we use the most when assessing disease severity. But I think it's important to recognize some of the limitations of that. So SALT score only evaluates the percent of hair loss on the scalp. And we know that severity, really, there are a lot of things that contribute to that, right? Does the patient have involvement of eyebrows or eyelashes? And honestly, for me, kind of the biggest thing is, how is it impacting them? How is it affecting their everyday life? And so there are rating scales for eyebrows and eyelashes, and there's also something called the Alopecia Areata scale, which a group of us who do a lot of hair loss got together and created, which is meant to be more of a holistic assessment of severity of alopecia areata. So it takes into consideration not only percent scalp hair loss, but also the presence of other things like psychosocial impact or involvement of eyebrows and eyelashes, rapidly progressive hair loss, and then also, failure of treatment. So I think we use a SALT score and it's important, but remembering that there are other tools available, I think is also really important. So for this patient, we've kind of already said that he's beyond intralesional corticosteroids, he's beyond topical. So what are our options for him? And again, this is a patient who really, in my opinion, warrants systemic therapy, has severe alopecia areata, is having a clear negative impact on his life, and he wants to do the thing that will get him back to normal as fast as possible. So a few years ago, we didn't really have a lot of options for this patient, but now there's actually an FDA-approved drug for severe alopecia areata in patients age 12 and up. And so that medicine is called ritlecitinib, and this patient is definitely a candidate. So we talked about ritlecitinib, family was on board, and most patients starting on a JAK inhibitor, which ritlecitinib is. I also add oral minoxidil because we've seen that there's kind of a synergy there in many cases. And so, oftentimes people get there a little bit more quickly if you have the minoxidil on board also. So once we have the conversation about ritlecitinib, we go through sort of expectations, adverse effects, potentially. We talk about the box warning, which is really important that patients are aware of. And then we need to check some blood work. So in this patient, we want to make sure his blood counts are normal, make sure he hasn't been exposed to tuberculosis or hepatitis, and then check liver and renal function. And for him, those are all normal. And we're lucky that, a majority of patients with alopecia areata, especially teenagers, tend to be very healthy at baseline. So it's not super common that we see, a lot of abnormalities there. So this is a patient, so we get started on ritlecitinib. We added minoxidil 2.5 milligrams daily also, and ritlecitinib is just one dose. It's a 50 milligram daily dose, and that's the same for all patients 12 and up. And so one thing that's really important with hair is that it takes a long time to grow. So one of the things when a patient is starting, we have to kind of set expectations that this is really more of a marathon than a sprint. And, I think patients are really, they're okay with that. They understand, but I think, letting them know that this is a medicine that gets rid of the inflammation that's leading to hair loss and not a medicine that just grows hair is really important. So in follow-up, for ritlecitinib, we need to check a CBC at 4 weeks to make sure lymphocytes and platelet counts especially are normal. And then usually I tell these patients I want to see something happening by 3 to 4 months. Everybody takes a different trajectory. There are some patients who grow very quickly, other people who are this sort of slow and steady. And then there are some people who are what we call late responders, where it takes many, many months before you see much happening. And so when this patient came back at 4 months, amazingly, he had near complete regrowth of his scalp. And he, not only looked like a different person, he felt like a different person. And really, he just felt like himself again. And that's what we're trying to do with these patients. It's, some people say that this is cosmetic, but cosmetic means we're trying to enhance their appearance, right? We're not. We're just trying to restore normal. And so he's starting to feel back to normal. He's starting to get some regrowth of his eyebrows and eyelashes. And I would anticipate those will continue over the coming months. And so at that visit, making sure he's tolerating it well and having, no side effects, which he isn't, and then having a conversation about, what happens from here. So most patients, if they're doing well at 3 or 4 months, I might see them back, kind of depends, but maybe anywhere from 3 to 6 months after that. For the majority of patients, treatment is going to be chronic because this is a chronic disease when it's severe. And so usually we just get patients to have complete regrowth. We leave everything alone. And patients who have a feeling that they'd like to try to potentially reduce the dose, we can consider that at some point. But importantly, we never just stop the medication or even just cut the dose in half, because if you start to lose hair, you're kind of going back in time a long time, right? The stakes are really high. So any taper, most patients don't end up doing a taper, but in some cases you can think about that, but it has to be done very slowly. So fortunately, this patient did very well with treatment and, continued to have a really good response. And, he really feels like he's getting his life back. And I think that's something for all of us to remember as healthcare providers is this, we all went into medicine to help people. And this, I have to say, I may be a little bit biased because I do a lot of it, but it is really rewarding and meaningful and so much fun, not only to watch hair grow, but to see patients coming back and, really feeling so much better because of a decision that you made with them. So thank you for watching.